Welcome to this Global Health series. I'm Vivian Kosinja-Birchall, your host, and my special guest is Dr. Satish Gopal, who is the Director for the Center for Global Health at the National Cancer Institute. I hope I said that right.
You did.
Welcome to our series.
Thank you.
Could you please tell us about what you do at the National Cancer Institute, and then we'll take it up from there.
Sure. So I direct the Center for Global Health at the National Cancer Institute in the United States, also known as the NCI. The NCI is the largest funder of cancer research in the world, and we have a dedicated center which is really focused on fulfilling our responsibility as the largest funder of cancer research in the world to make sure we're maximizing our global impact. And then we also try to drive forward programs that are specifically focused on cancer research opportunities in low and middle income countries principally.
And maybe for the sake of our viewers who don't know much about you, could you tell us about your history with Africa?
Sure. So I started I was recruited to the National Cancer Institute in 2020, actually just a few weeks before COVID is when I started. Before that, I spent basically a decade in my academic life living and working in Africa, a couple of years in Tanzania, and then 8 years in Malawi. And I worked as an oncologist. I took care of cancer patients in the public sector. I lived there with my family. And then I led an NIH-supported cancer research program where we really tried to ask and answer questions that we thought were important for our local settings, but that would also generate knowledge that might be applicable and valuable for the cancer research community more generally worldwide.
Yeah, and the reason I wanted you to mention that history is because Africa has been hit worst, I think, if I dare say, by cancer. And it's not, the projection is scary. I think when you look at cervical cancer, it's the #1 number of deaths among women in many of the countries. Actually, the top 10 cervical cancer fatalities in the world are from the sub-Saharan Africa, if I'm not mistaken. So when you're talking about improving research, how much of that emphasis is on African research?
A lot of it is. So first, let me just step back. I think you're right. The statistics are really alarming. I would say that the statistics are likely underestimated for a whole variety of reasons that I won't go into. And this is primarily actually what attracted me to a career focused on my own personal career focused on cancer research in Africa. I lived in Tanzania from 2007 to 2009. And it was clear already then to me how much cancer was occurring. There was not a lot of discussion about it. There was not a lot of research dedicated to it. So this looming public health threat and the idea that we really needed smart people thinking about it in a serious way is much of what motivated me to pursue a cancer research career. We know that Africa historically has been relatively underrepresented in cancer research despite the tremendous burden that you described, which is only going to increase going forward. And so at the NCI, we are very focused on trying to ensure that we support research all around the world that will have as much global impact as possible. In particular, there's some cancers that occur with very high frequency in Africa. For example, cervical cancer, cancers associated with HIV. So not only is there tremendous need, but I think there's really important opportunities that we frankly won't be able to actualize without collaboration with African partners and without really cultivating a scientific culture that's focused on cancer within Africa.
Right, and you mentioned the relationship between HIV and cervical cancer. And again, when I looked at that list of the top 10, highest incidences in the region. We have Eswatini, Uganda, all those have also high incidences of HIV. In terms of research, how much of it is collaborative between those researching HIV and those researching, for example, cervical cancer? I'll start there.
So I think it's very collaborative. You're right. So all around the world, when people with HIV are treated effectively for their HIV, a primary cause of death becomes cancer. We have seen that, and actually the leading cause of death becomes cancer, because infectious causes of death decline and people live longer, and aging is a very strong risk factor associated with cancer, in addition to HIV contributing to increased cancer risk for a number of different cancer types. So we've seen this already happen in the US. It's starting to happen in African contexts as well. This epidemiologic shift is underway and is very, very clear. HIV is also where a lot of research investment has been in Africa over many decades. So in addition to there being a large burden of HIV-associated cancers in Africa, there also is a research infrastructure there that is very well equipped and has been focused on HIV. So we are thinking a lot about how to leverage that infrastructure to study HIV-associated cancers and then cancer more generally. And the NCI supports a large portfolio of work focused on HIV-associated cancers in Africa, and we're leveraging that more and more to study cancers in people without HIV as well.
Right, and one of the research I found missing when I was researching cervical cancer, I just did that for my master's, and it was the data on the implications or costs of cultural influence to the disease. Yes, there's some, but it doesn't really tell the story when you're thinking about the patient journey of a lady, a woman in sub-Saharan Africa who is heavily influenced by culture. Is that something that the NIH looks into as well? And how has it informed where you put the money?
Yeah, so we do. Historically, you're right, it hasn't received as much attention as it should. A good example of this was really during the recent COVID epidemic, where, I mean, the speed with which we developed effective vaccines against COVID was truly remarkable. But then we had a hard time actually penetrating certain communities where there was a lot of mis and disinformation. So I think similarly with cancer, we often we need to continue finding new tools, and we support a lot of research around that. But then even once the tools are available, how to deliver them to populations, communities with the kind of scale and sustainability and penetration that is needed, I think there's a lot more rigorous research that can be done around those questions that we historically haven't spent as much time on. We support a big portfolio of what we call implementation science at the NCI, both domestically, and over the last several years we've grown that portfolio substantially in low and middle income countries, including in Africa. And it's focused on exactly the questions that you're raising. That is, even once you have a tool available, like HPV vaccination or effective cervical cancer screening, how do you have trusted messengers deliver the need for that intervention into communities so you can get the kind of uptake and scale and sustainability that is needed? There's a lot of important science to be done around those questions, and I think we're supporting a growing portfolio that's really focused on that.
I'm glad you mentioned the trusted messenger, for lack of a better word, because part of what I learned through my research process was there are certain issues that communities or women, if you're focusing on cervical cancer or women's health, that they are not going to discuss with scientists or researchers, especially if they're foreign, because they are very cultural. For example, how they are very hesitant to discuss how their body and anatomy is changing or is changed or transformed because of cultural reasons. And when we're talking about sexual behavior, there is that hesitance. So to what extent is NIH considering or factoring in that in the kind of research that you fund?
We're considering it a lot. You're right. I think scientists and doctors, and I am both, so I think it's okay for me to say this, are notoriously bad communicators, right? We often, I think, assume that once we publish our paper that this is automatically going to get taken up into communities, and I think we've learned over and over and over again that's not what happens out in the real world. again, I think our portfolio around implementation science is intended to try to address some of these questions. That is, for school-based vaccination programs, like for human papillomavirus to prevent cervical cancer that's getting scaled up in Africa and many other parts of the world, those are generally based in schools for girls before they have their sexual debut. We've learned that the influence of teachers in that environment is very strong. So we're supporting research, for example, that's focused on having teachers message HPV vaccination, since this is being delivered in schools in the right way. We've also thought about our supporting research that's engaging mothers and daughters together. So the mother comes from screening at the same time that the daughter comes forward for vaccination. So we're engaging them as dyads rather than as separate units, understanding how important family structures are in African context. So you're right. I think there's a lot more work to be done in this area, but I think we have to be willing to support this kind of research if we want the interventions that we already know work to get adopted at the level that we want.
Right. And how much of that research goes toward communication?
I would say some, but not enough. I mean, I think that's the reality. And the other thing to acknowledge is we live, globally now in a very, very challenging and difficult and rapidly changing communication environment, right? Social media has really changed everything fundamentally. There's controlling what information people have access to. Platforms are coming offline and online, every year. Some platforms are very common in some parts of the world, but less used in other parts of the world. So I think there's a lot more that we could support in this area, how to get high quality information to people. We have done some research around this, but I think there's certainly more to be done, particularly as we try to influence cancer control policies and practices at a large population scale. I think this kind of research is essential.
Right, and then during your talk earlier, you mentioned Uganda. I'm originally from Uganda, so I was touched by that because I had talked to the director of the Uganda Cancer Institute, and he had mentioned that, how the origins of this cancer research. And so it's good to see it being talked about at this on this platform. So in terms of giving back to communities like that, what are your strategies to make sure that these communities are not left behind?
I think we're trying to support the full spectrum of research. So, basic biology and etiologic research continues to be incredibly important in the US and everywhere in the world. But that isn't all that we do in research, right? We also have research that is focused on new treatments and testing them and implementation science. And so I think people all around the world deserve the entire continuum of cancer research rather than simply being confined to one narrow segment of cancer research. And I think that's what we're trying to bring and invest in more all around the world, including in low and middle income countries, including in Africa. Historically, they have contributed samples basically, and have participated in more biology and etiologically based research, and then haven't been able to benefit from some of the fruits of those discoveries. And so we're just trying to ensure that there's a more balanced spectrum so that clinical trials, implementation science, some of these opportunities to benefit from new advances is possible for people all around the world. And then ensuring that as new evidence is generated, trying to do what we can as the NCI, understanding that we don't have a direct policy-making or implementing role, that we can ensure that our science is disseminated to the stakeholders that matter in making those decisions.
Well, two things. The first is, I was having a conversation with a friend, and we were joking about scientists and researchers, that the goal for these researchers is to publish. And after the publication, that's checked off. Oh, I published a paper, and leave it to whoever cares. So what has been your experience with that? Because we don't want to spend a lot of money on just research and people publishing and not being able to translate whatever they've published into meaningful information for their communities.
That is the historical model, and I think we need a new model, and I think we're thinking a lot about that at the NCI and trying to take our work further than it has We've drawn narrower boundaries, and I think we're trying to move beyond those as we go forward. A good example of this is some of our work in implementation science, where the research actually includes stakeholder engagement with ministries and governments and implementers in the design of the research, so that they're involved in the critical early phases, and also we can ensure that the projects that are being developed are really addressing real needs of those communities and those environments. We're doing the same even with some of our clinical trial work, where when trials are done in Africa, we're trying to not just hand over the protocol and ask our colleagues to implement it, but trying to ensure that we're designing trials that make sense for that environment, where there's often different health system infrastructure, where there's often different standards of care than what we're accustomed to in the United States. We're actually increasingly trying to involve patient advocates in those discussions, that is the design phases of those trials, so we can ensure that they're asking and answering important questions. And then also making sure that we include economic evaluations, et cetera, so that, because that's the kind of data that ministries need. Even if we test a new treatment and know that it works, ministries want to see what is the budget impact, what are the economic implications before they decide to make these treatments available at a large scale in their environments. And so we're trying to do more of that work. So, again, do what we've always done, but take it further so it gets closer to the kind of evidence and information that policymakers and practitioners need, even in African settings.
Right, which is great for the new self-screening, self-collection for the cervical cancer. I think that came out of a lot of research, and I hope that it can translate into communities in low and middle income countries.
There's a lot of innovation happening already in Africa and in low and middle income countries. I think self-collection is an excellent example of this, where many countries are trying to move in that direction even before we have an approval for self-collection in the United States. And they're doing this out of necessity, right? Because they know they don't have pap smear and cytology that can be applied at a population scale. So I think there's a lot of innovation happening out of necessity. I think that you have smart, talented people who are aware of the available evidence and are trying to solve these problems in a way that suits their communities and their environments. So there's a tremendous innovation potential. And actually, in many respects, many African countries and investigators and scientists and clinicians are moving even faster than we're moving in the US. We sometimes have these established high quality standards in the US, but they can be quite rigid, and they're difficult to change because there's a lot of inertia in the system. So I think in many respects there's opportunities to go faster with respect to innovation in African settings.
Right, and then one of the last things I'm going to ask is similar to what I asked Dr. Young earlier. When it comes to research and partnering with, with the health community, how much work do you do partnering with nurses? Because, for example, in low and middle income countries, they spend more time with patients. They understand the patients sometimes better than the executives of these hospitals and oncologists and doctors. To what extent also do you fund their research, if at all? And are there opportunities for them to engage in research?
Yeah, so nurses are critically important. I mean, during the decade that I lived and worked in Africa, if we had an opportunity to hire a nurse or hire a doctor, we always hire nurses because they're so much more impactful in many respects on patient care and the cancer journey, as you described. We do support nurse scientists. I think they're not probably supported to the degree that we need. But for example, I think we have training programs that are really trying to encourage nurses to become nurse scientists. We did a lot of this in our own program. They often are very focused on the questions that matter most to patients. They're often not trying to identify the mutations in a patient's tumor, but they're focused on questions about symptom management and survivorship that really matter a great deal to patients, financial toxicity. So I think cultivating a cadre of nurse scientists in Africa is critically important. We are doing some of that work, and I think certainly can do more, and probably need other partners like the Oncology Nursing Society in the United States. They are trying to establish a more global presence, I think, to really lift up that profession and cultivate real leaders within that profession who can help raise the important issues that you've highlighted.
Yeah, I think it will be great. And since we are at the Global Health Catalyst, can you tell us about your relationship with, or what you envision in what ways you envision to work with the GHC to advance the work that you do?
So I mean, the Global Health Catalyst is a kind of a really nice convening organization. I mean, they have this yearly summit and they bring together people from government, funding agencies, private sector, advocacy community. So I think, and I think the moonshot effort that Dr. Young leads really exemplifies this as well. With the first phase of the moonshot, that was largely a research effort in the United States where we at the NCI benefited from substantial new resources that were provided to us to drive key areas forward in cancer research that we thought could be accelerated with a dedicated focus and effort. This reignited phase of the cancer moonshot, as you probably know, is much bigger. It's all of cancer, all of society. And so we're a piece of it, and I think a very important piece of it at the NCI, but we know that it's going to take all of us to try to address this major societal challenge. I think that's embodied in the Global Health Catalyst Summit as well, where it's an opportunity for stakeholders who have different capabilities, different agendas, to all kind of get together and think about how we tackle this immense problem together. So we're really grateful for the opportunity to participate from the NCI and connect with partners and look forward to continued participation and collaboration opportunities that will arise out of this meeting.
Right, and then finally, it's not related to science, but what are some of the misconceptions people have about the National Cancer Institute that you've heard of in terms of what you guys do?
Well, so I came there from Africa and had never worked at the NCI or in US government before. So I sometimes joke that I went from probably the place with the least cancer resources to the place with the most cancer resources. So I think I do have an interesting perspective on this. I think it's easy to think of the NCI as this ivory tower where we have all the resources that we need and that everybody knows everything that there is to know about cancer. And I think one of the amazing things for me personally about working at the NCI has been just to demystify that. There are some amazing, amazing people, some of the most amazing people I've ever worked with, but we also have to make difficult choices about how to allocate our resources, how to prioritize the various opportunities that are available to us. We often have to identify and be humble about areas where we don't know as much about cancer as we might, or where we haven't supported research in the way that we might. Obviously, we deal with a larger political and funding environment as a federal agency that relies on Congress. So I think just in many respects, I often feel like I'm wrestling with the same kind of considerations that we wrestled with in Malawi, and so that has been very, very enlightening for me. And I think, again, I think the NCI is a really amazing place, and I think the reality is we're struggling with a lot of the same kind of challenges and opportunities and needs and how to prioritize them that the entire cancer research community is. And I think we have the great fortune of having a really important platform and a really high level of government support. Perhaps never more than in the current administration, and so that I think enables us to do a lot of work and support a lot of really important work on behalf of the enterprise more generally.
And finally, for people out there who might be considering, say, creating a partnership with the NCI, what are the best ways to approach this?
I mean, you're always welcome to reach out, and we are certainly happy to field those inquiries at the center and try to direct them. The NCI is a really big, complex organization, so we can try to direct them as would be appropriate. Much of the work that the NCI conducts and supports is through grants and contracts, just like the rest of NIH, and so there are always opportunities that might be of interest to people. These are generally, communicated on our website, on our social media, both at the NCI level and also at the Center of Global Health. So there's always opportunities that might interest people, and just encourage people to follow us on our website, on social media, whatever platform is most friendly to you, and stay in touch with things that the NCI is doing, and try to participate and apply for opportunities as they arise, when they're well aligned with your work and your interests.
Well, thank you so much for being my guest here on Global Health Series.
Thanks for having me.
And thank you for the work that you do, by the way. I should have said that first.
Thank you.
Yeah, we appreciate it.
No, I thank you for that.
All right. And to our viewers, thank you for watching this episode of Global Health Series. Until next time.